Hi and welcome. Thank you so much for taking some time to sit down with me today and learn about brain injury. So I'll be presenting what we call the Brain Injury Association Brain Injury 101. So I'll get into what that means in a minute. But I wanted to tell you briefly about the Brain Injury Association of Maryland and my role, if you don't already know. So the Brain Injury Association of Maryland is the state affiliate of the Brain Injury Association of America. We have been around by one name or another since 1983, when families of people with brain injuries were looking for support and services and were struggling to find it. And so they came together and started this advocacy in Maryland. And so we continue that, to this day. We do a lot of different projects. We do health education, which is me, which is why, we're here learning together. We operate a helpline and a resource line for people that are still, like the families that were looking for help in 1983. Families are still looking for support. Individuals are looking for support and services and just different information too. So we provide all that. We do advocacy. We have an educational conference each year. We support research. I myself am a case manager for the TBI waiver program, which is a pretty small Medicaid-based waiver for people with brain injuries. So that is my role. That's a little bit about us. I'm also the health educator, as I said, and I do use she and her and hers pronouns. So what are we going to be doing today? First, I'll welcome you. Thank you again for joining. I'll talk through some housekeeping on the next slide. We'll start with an opener. We're going to do a Q&A, which sounds kind of silly on a recorded webinar, but I'm just going to pretend you're still right there, and I'll ask you questions, and you can feel free to just say it in your head or out loud, whatever works for you. We'll do a broad brain injury overview, hit some of the things that I think are important, and then we'll talk about special populations, so certain groups of people that we know have a higher incidence, perhaps, of TBI, or groups of people we know are more susceptible to TBI. We'll spend a little bit of time talking about mental health and substance use. As you'll learn, there's a pretty strong connection between mental health and substance use and brain injury. And then we'll talk about support skills. So how can you support somebody with a brain injury? What are some things you should know? And then I'll talk through some resources that are in Maryland. So of course, we're not going to cover everything there is to know about brain injury, but this will be a start. And you'll hopefully learn something along the way. So in terms of housekeeping, I'm not sure when you're watching this, but when I'm recording this, we are currently in shelter in place during COVID-19. COVID-19 is scary and intense for a lot of reasons, but I think it's at least shown me to think about my mental health a little bit more. I hear a lot of coworkers and friends just checking in more. So I wanted to bring that into this space as well. If there's something we can learn from a pandemic, it's maybe how to be more gentle with ourselves, maybe. So I'll just ask you, before we get started, are you comfortable? Do you need water or tea, or if it's the morning, do you need some coffee? Do you feel like you're in a good space to take in new information? Sometimes I know I'll sit down for a webinar or a class or something, and my brain is just moving in at a million different, well, basically I'm all over the place is what I'm trying to say. So if you're feeling like that, maybe now is not the best time to take in some new information or revisit old information. It's okay to come back and revisit this at another time. And just so you know, there are some breaking points throughout. So where I'll encourage you to get up and stretch or get some water. And so those are kind of natural points where you can just take a break and step away if you need to. Okay, so the first part of this, like I said, is questions and answers. So I will read them out, the question to you, I'll read the answer, I'll ask you to guess, and then I'll explain it. So you'll see how it works once we start going. So the first question is, how much does the adult brain weigh? And your options are 1.5 pounds, so a little teeny thing, 3 pounds, or 5 pounds. And the answer is 3 pounds. And it reaches that weight, surprisingly enough, at 12 years of age. The next Q&A is actually a statement. So the statement is that men are twice as likely to sustain a traumatic brain injury as women, or than women. Is that true or false? Are men more likely to have TBI? That is true. And we will talk about that in a little bit, if you put a pin in it, as to why that might be the case. Next question is, which of the following is an example of a compensatory strategy? So a compensatory strategy, if you don't know, is a behavioral or environmental strategy that kind of helps you bypass maybe an impairment or a deficit as a result of a brain injury, for example. So it helps you function, and it's something in your environment that helps you function. So now that you know what that is, do you think a day planner is a compensatory strategy? Are alarms on cell phones for tasks or reminders? What about step-by-step instructions written out or typed up? And so those are all going to be compensatory strategies. These are really helpful for some people. One thing to know is that brain injuries are very different person to person. So one person might love their day planner, and the next person, no way, you wouldn't catch them dead with a day planner. So compensatory strategies can be a really great way to support cognitive functioning, but it always has to be tailored to the person. All right, and then we have the big question. By that I mean it just got a lot of details in it. But how many people would you guess are treated in the US in emergency departments, hospitalized, or die as a result of a traumatic brain injury each year? So how many people each year are we capturing in a medical setting that are sustaining traumatic brain injuries? So your first guess is 231,840. The next option would be 2.8 million. And the last one is 1.2 million. So I'll give you a second to cast your vote. And the answer is 2.8 million. And I'll break that down in a minute, but I just wanted to share that the first number, the 231,840, is the number of people each year that are diagnosed with invasive breast cancer. And then the other number, the 1.2 million, is the number of people in a given year that are living with HIV or AIDS. And so I don't bring those numbers up to draw a distinction or to say that one is more important than another. You know, those are all very difficult health problems, but rather to show you just the size and the scope of brain injury. And the thing about that number too is that those are the people that have gone to the ER, that have gone to the hospital. But we don't know about all the other people who don't go to the hospital, or don't seek out support, or maybe don't even know that they have an injury. So really the number is probably a lot larger. But even so, let me go ahead and break that down for you. On this next slide, there's an infographic, just sort of shows you the breakdown, but it tells us that about 56,000 people of those 2.8 million do die. About 282,000 people are actually hospitalized, require some more intensive care. And the majority, most people, about 2.5 million people, are treated and released from the ER. And again, that doesn't count for people that aren't even going to the ER. And if I can draw your attention down to the corner of that infographic, it says that about 15% of those diagnosed with a mild TBI might have long-term problems. So a lot of people do okay, but there is a certain percentage of people who will struggle with more long-term problems, which we'll get to, or long-term changes rather. All right. So for those of you who care about celebrities, which of these celebrities has not had a TBI? So that's kind of a confusing question, but another way to think about it is 3 of them have and 1 of them has not. So has Tracy Morgan? Has Ben Roethlisberger? Has Anne Hathaway? And has George Clooney? I'll let you pick which of those people has not had a brain injury. So going down the line, Tracy Morgan has had a brain injury. Usually when I ask this, I'd say most people know about his accident. He was hit by a tractor trailer and was actually in a coma for 8 days, which is that's considered a severe brain injury. But he's making a comeback. He was just on SNL a couple of months ago, and seems to have kept his sense of humor about him. Ben Roethlisberger cracks me up when I ask this question with people because they're like, yeah, duh, moving on, next. I think it's a good thing that a lot of people know that high contact sports are giving people a lot of concussions, a lot of brain injuries. And one thing to know about sports players, but other people that have multiple brain injuries, is that even if it's a more mild injury, so a concussion, if you have a couple of those or more than a couple, if you have several, they have cumulative effects. So rather than it just being, one concussion here, one concussion there, the effects kind of build on each other, and it can resemble then a more moderate or severe brain injury. Anne Hathaway. And then what about George Clooney? So Anne Hathaway, as far as we know, hasn't had a TBI, but we can't always know that. The one that sometimes stumps people is George Clooney, because people will be like, well, he looks good, he's still out there directing and making movies or, whatever he does. But he was filming a movie, Syriana. Haven't seen it. I don't know if it's any good. And he was filming a fight scene and he fell. And he started having a lot of pain and memory problems. And he was starting to, I think, direct and star in another film after that. And he said he had Post-it notes all over the wall with reminders of, to do this or that, or this line or that line, talk about a compensatory strategy. And he was in so much pain and was struggling with depression that he was thinking about hurting himself. He went to his dad, and his dad was like, you need to get some help and see somebody. And he ended up having a brain surgery. He's someone that, I bring up because people are like, well, he looks good. He's doing fine. But plenty of people look good and still have injuries. It's really one of those disabilities that you can't see, it is invisible. And that's my little PSA to sort of treat each other kindly and not assume that we know if somebody's had an injury or not, right? We can't see that. All right, so let's talk about brain injury a little bit more. So what in the world is a traumatic or acquired brain injury? So you'll hear me throughout this presentation mostly say TBI, traumatic brain injury. In the US, at least, acquired brain injury isn't used as much. If you look more at New Zealand, Australia, even England, they'll say ABI a little bit more. But you'll mostly hear me talk about TBI. So what the heck is it? A TBI, the key piece of that traumatic brain injury is the trauma. So there is an insult to the brain that's caused by an external and physical force. Something outside of you is hitting your head and causing an injury. Examples could be, there could be a lot of examples, but I've listed just a few. There might be falls, car crashes, sports injuries, assaults, things like that. So then what's an acquired brain injury? An acquired brain injury, or an ABI, is defined as an insult to the brain still that occurs after birth that's caused by internal factors. So that might be, the way I think of it is that that's usually more medical things. So a stroke is a brain injury. If you have an aneurysm, if you have a tumor or brain surgery and then you start having cognitive changes, that could be an injury. A lack of oxygen to the brain. After about 3 to 5 minutes without oxygen, your brain cells start to die. So that's a brain injury too. And we're seeing that now with the opioid crisis where people are overdosing. And so thankfully they are being brought back by naloxone. But if they've gone for a little while, you know, that 3 to 5 minutes without oxygen, they're starting to have an acquired brain injury. And then TBI also is considered an acquired brain injury, right? Because it's something after birth. Another way to look at this is with this umbrella. So the umbrella is acquired brain injury, and under that is everything else. So you have an aneurysm, like I said, a lack of oxygen, a tumor, a stroke, and TBI, okay? So then I wanted to talk about what is happening when you have an injury, what's going on. So first things first, some people have told me this is a little gross. Okay, so you can skip ahead if you want, but your brain is your brain's soft. It's the consistency of cooked cauliflower or Jell-O, right? That's pretty soft. And our skulls, by design, are very tough and very hard. They also are not smooth on the inside. They're bony ridges. And so if you are hit by something, your really soft brain is going to hit your really hard and somewhat jagged skull. Okay, so I'm going to show this video that just sort of shows you what's happening inside your brain if you get hit. So you see that soft brain coming into contact with the skull and being jostled. Now, obviously, this is dramatized because we have cerebral spinal fluid that helps secure things. Our brain doesn't just wobble around like that all the time, but that just shows you how it moves and then how that injury can happen. So there's like the physicality of the injury. You know, if that hitting that bony ridge causes bruising or bleeding or an actual like penetration, that can happen. But there's also something happening at a cellular level with your brain cells. So we're going to watch a brief video to describe that because goodness knows I will really confuse you if I try to explain it myself.
Each year in the United States, players of sports and recreational activities receive between 2.5 and 4 million concussions. How dangerous are all those concussions? The answer is complicated and lies in how the brain responds when something strikes it. The brain is made of soft, fatty tissue with a consistency something like Jell-O. Inside its protective membranes and the skull's hard casing, this delicate organ is usually well shielded. But a sudden jolt can make the brain shift and bump against the skull's hard interior. And unlike Jell-O, the brain's tissue isn't uniform. It's made of a vast network of 90 billion neurons, which relay signals through their long axons to communicate throughout the brain and control our bodies. This spindly structure makes them very fragile, so that when impacted, neurons will stretch and even tear. That not only disrupts their ability to communicate, but as destroyed axons, begin to degenerate, they also release toxins, causing the death of other neurons too. This combination of events causes a concussion. The damage can manifest.
So I hope that that makes sense in terms of what's happening with your brain cells and your axons. So there's that sort of stretching and pulling apart, which is called shearing, and that, you know, makes your brain cells not communicate to each other. And so that's also what's happening as well when you have a brain injury. So then another question for you, what would you guess is the most common cause of a TBI or a traumatic brain injury? I'll give you a second to take a stab at it. All right, so I will break it down for you. Now, just to note that these are common causes of non-fatal TBIs. The fatal TBIs have different leading causes, one of which is actually suicide. So we'll get into this a little bit more, but there's a strong relationship between TBI and mental health and TBI. But in terms of non-fatal traumatic brain injuries, falls are actually the leading cause of brain injury from our most recent data from the CDC. And those make up about 40% of brain injuries, 47%, I'm sorry. After that, you get into the category of struck by or against something or someone. So that could be anything from like an injury at work where you're hit by a beam or goodness knows, you know, anything, to a contact sport where you're struck by or against somebody or something. And then you have car crashes coming in at about 14%. Before I started this job, I probably would have picked car crashes just because that's what I see the most of, at least in Baltimore City. I don't know about you guys, but it's actually falls. After traffic incidences, we have assault, you know, people getting into fights. And after that, there's an unknown category. So it's, in some ways that's self-explanatory, but let me walk you through what that might look like. So somebody might be found down anywhere, right? They're not responsive, maybe outside, or, you know, somebody is, found down. And somebody calls an ambulance, they go to the hospital, and they can see based on whatever imaging they do or whatever test they do that there's been a brain bleed or there is damage to the brain for some reason, but they don't actually know what happened. And so that's an example of an unknown cause of TBI. And then other is the last category, 7%. So that's anything else that might cause a brain injury. And then there's some different levels of severity too, right? So it's an injury. And so just like you have a twisted ankle, a fractured ankle, a broken ankle, there's going to be sort of levels of severity for a brain injury too. I'm not going to go too in depth on this, but there's just a couple of facts I'd like you to know. Most brain injuries are mild. 80% of brain injuries are mild, meaning that they're concussions, right? Those are interchangeable, mild TBI and concussions. And so what makes a brain injury mild? There's a lot of different factors you could consider, but some that I wanted to address are consciousness and loss of consciousness. So if you have lost consciousness for less than 30 minutes, chances are that will be a more mild TBI. But you don't have to lose consciousness to have a concussion. So I know if I have a friend that's in a car crash or falls, my first thing is to ask about, are you feeling dizzy? Are you feeling a little out of it, a little loopy? You know, I'll talk to them about things that might indicate an alteration in consciousness. And that could be a TBI too. You might also want to think about post-traumatic amnesia. So there's a couple ways to describe what this is. The way I think of it is sort of the time frame after an injury that somebody doesn't really have a recollection of. So if you work with people with brain injuries, you're probably familiar with this. Like they remember maybe things leading up to the accident or injury, and then there's a period of time afterwards where they'll say, I don't know, I woke up in the hospital, a week later, or I woke up when I was in the ambulance, and your brain is trying to protect you from that. Another way to describe this is it's a period of time after your injury where the lights are on, but nobody's home. So you might be talking to me, you might seem totally normal, but if I come back to you next week or tomorrow and say, hey, do you remember that conversation we had after your fall? You're not going to remember it. So you still know who you are, maybe your address, but you can't take in new information. So that's another thing people might look at to determine severity. And then there's also the Glasgow Coma Scale. So that looks at how alert you are, how responsive to stimuli you are to see if you're in a coma or, more or less responsive. Okay, so then as we move through the severity levels, those factors on the right-hand side are going to change. So a moderate brain injury, it's about 10 to 13% of injuries. You're going to have a longer loss of consciousness, so 30 minutes to a day. That period of post-traumatic amnesia is going to be an hour to a day. And the Glasgow Coma Scale, I didn't include the ratings, but it's, I believe, a high score of 15, so you could look at that if you would want. And then more severe injuries are going to be where you've lost consciousness for over a day, and that post-traumatic amnesia is lasting over a day. And so usually that's when people will say you're in a coma or maybe a vegetative state or minimally conscious. And that's about 7 to 10% of injuries. And I wanted to talk about risk factors. So in the Q&A, I was asking if men are more likely than women to have TBIs, right? There are some people that are more likely to have injuries. So the first group is going to be age. That's not a group, but people who are younger, young children, or older adults are going to be more likely to sustain TBIs. And that's because of falls. And we'll talk about those groups later. But adolescents also have higher rates of TBI because of car crashes. I have 5 brothers, and I saw how they drove when they first got their license. They weren't, didn't make the smartest decisions. And then 2, intentional injuries. So that is something like a suicide attempt, right? Might lead someone to have a brain injury. The next group, and this isn't all encompassing, this is just a couple of key groups that I wanted to highlight, are people with lower income. And there's some, specific reasons for that. So there might be, if you have lower income, you might have decreased access to preventative measures, baby gates, or a lack of a safe place to play. Or if we're thinking about acquired brain injury, which is something like a stroke or, like an anoxic injury, it can also be things like lead poisoning. And you see lead in the water and in the paint, particularly in poor communities of color, which we could spend a lot of time talking about, but that's not what we're talking about right now or today. But another thing about income is that across the board, when you think of social determinants of health, the lower your income, the worse health outcomes you have, and TBI is included in that. Or right, if we're thinking about ABI and stroke, we know that poorer people have higher blood pressure and other health problems that might lead them to have an injury. And then gender, now we're getting to that question. So yes, men are twice as likely to sustain TBIs. A couple of reasons for that. I think the funniest reason that I've heard one giving this talk was that somebody said, well, if I'm at the bar, my husband says, hold my beer before he gets into a fight. And, you know, she was joking, but one of the reasons men have higher rates is that they do engage in more risk-taking behaviors and have sort of more risky behaviors. There's also the fact that a lot of contact sports are played by men, so hockey, ice hockey, boxing, football, blanking on all my sports today. And then also their professions. So men that are in construction or in like safety type of jobs, they are more likely to be injured on the job than women. And so there are some other groups that have more behavioral risk factors, so behaviors that they're engaging in that make it more likely that they'll sustain a brain injury. So people who misuse drugs or alcohol are more likely to sustain traumatic brain injuries. And if we use the example of alcohol lowers your inhibitions. It might make you a little more impulsive. And I also think of it as like slowing down your cognition and your executive functioning, right? It's a depressant. And so you might not have the best judgment. You might not be making good decisions. You might fall and sustain an injury that way. And then people who are often violent or violence prone or in close proximity to violence are going to have more TBIs. So if I have a group of friends and they're always getting into fights with other people, that might mean I'm more likely to get hit and have a TBI. If you're in close proximity to violence, so if you're a child that is abused, you might have a TBI. Shaken baby syndrome is a traumatic brain injury. Or if you have, you know, a spouse that is violent towards you, you're more likely to have a TBI. And then another thing I wanted to touch on is that if you have a history of a traumatic brain injury, you're going to be more likely to sustain another brain injury. There could be a couple of reasons for that. It could be if you had an initial injury where your balance was affected, or you fell and, say you got in a car crash and had to have like your leg amputated, and now you're walking with a cane or something that's just new to you, you might be more likely to fall until you get comfortable with that. And as you'll learn a little bit later, something that can be affected with a brain injury is your impulse control too. And so you might be a little more impulsive, maybe just not think things through as much, and that could lead to an injury. And just so you know, so once you have your first injury, you're going to be 3 times more likely to have a second injury. And if you sustain a second injury, you're going to be 8 times more likely to have another injury. And like I said, with football players, these do have cumulative effects. And so you might notice more symptoms or changes, you know, as brain injuries are sort of compounding. So there are some groups of people that have multiple mild TBIs. So those multiple concussions that have the cumulative effect. Athletes are one group that I think a lot of people are aware of. But I'll ask, you know, if any of these groups are surprising to you or not maybe, but people who are homeless are more likely to have a history of multiple traumatic brain injuries. Same for folks with mental illness. Same for people who use drugs or alcohol. People who are incarcerated absolutely have higher rates of brain injury. And this is something that is really starting to be studied, and it's been surprising to me to see the rates of people who are in jail or prison with the TBI. And then, as I sort of mentioned earlier, victims of domestic violence or childhood abuse. We'll talk about most of these in more depth later. So let's check in really quickly. I'm going to ask you a couple more trivia. But what's the most common cause of brain injury? Is it A, car crashes, B, assault, or C, falls? And if you said falls, you are correct. I think we have one more sort of trivia question. After the first traumatic brain injury, a person is blank more likely to sustain a second TBI. So are they twice as likely to sustain a second TBI, 3 times as likely, or 5 times as likely? And if you guessed B, 3 times as likely, you are correct. So we're going to move on to the next piece of this, but now's a really good time to take a break. We're, I'd say, about halfway through. We'll have some more breaks throughout, but go to the restroom, stretch, have a snack. I know when I'm at my computer, I'm like, I always hunch over and then I feel terrible later. So, you know, pull your shoulders back, stretch them out. Just take care of yourself while we're working through this. All right, if you took a break, I hope you're feeling refreshed, and we will just keep going. So we're going to talk about anatomy next. I'm not gonna teach you any neuroscience. I really bring anatomy into it, so we just know just enough about the brain to understand why some people experience the changes that they do. So one thing that I really can't say enough is how important your brain is to everything that we do on a daily basis. Keeps us breathing, it keeps us sorry, I blanked, but it helps us communicate, it helps us get things done. And so if you have an injury to that super vital organ, it makes sense that things are going to change. There might be symptoms or challenges after that. So I'll start with the frontal lobe, and I'm really going to simplify your brain. It's very complex. So I'll just be talking about lobes, the 4 lobes in your brainstem, as a way to frame some of the changes that people have after an injury. So the frontal lobe is kind of the fingerprint or the signature of brain injury. Because it is big, as Stacia Edmonston says, it takes up a lot of real estate. And it's also at sort of in a vulnerable area. And so we see a lot of injuries affect the frontal lobe. And it's also responsible for some super important things, as you can imagine. It's responsible for our higher cognitive functioning, including executive functioning. If you don't know what that is, hold on just a minute. We're going to get into that a little bit more because it's really important. And some of the things that I'll say below or talk about next are examples of executive functioning. So your frontal lobe is responsible for executive functioning. Things like reasoning and your judgment. In some ways, it's responsible for your behavior and how you act. Absolutely plays a role in problem solving. Some people with brain injuries will struggle to problem solve after an injury. It plays a role in your emotions. It helps with your speaking and your communication and your voluntary motor activity. So my ability to move my hand, right? Or look to the right or to the left. So let's talk about executive functioning a little bit more. I find it sometimes a little bit hard to grasp because it encompasses so many things and is responsible for so many things. So I whipped out my dictionary, and Merriam-Webster says it is a group of complex mental processes. All right. It's a group of processes and abilities like reasoning and impulse control that control skills like organizing or managing time that are required for goal-directed behavior. So another way we could think about it is that executive functioning is like air traffic control. It is kind of keeping us on task. It's making sure that American Airlines can land in the American Airlines area. And it's making sure there's not another plane there at that time. I don't super understand air traffic control, obviously, but it's also, you know, you're maybe managing air traffic at a busy airport. There's a lot of departures, there's arrivals on multiple runways, and our brain needs those skills to filter out distractions, to stay on task and to stay focused, to prioritize things, to set and achieve goals, and then to control impulses. So if you think about that for a minute, that is a lot of skills that we need and we use on a day-to-day basis to get through the day, to know what we need to do at work or in our day. Do I need to get cat food today, or do I need to grocery shop, or do I need to pay my bills, right? What's the most important thing right now? And so I'd ask you to imagine how hard it might be if you have some changes or impairments in your executive functioning. So the temporal lobe is also affected, obviously, by brain injury, more so than some of the others, because that temporal bone is the thinnest in the skull. Okay, and this is going to be on either side as well. And it's responsible also for emotions. You'll see some repetition because the brain works together. It's responsible for memory, for hearing, for understanding language, and then organizing and sequencing information. And then the parietal lobe, that's going to be at the back, the upper back of your head. That's responsible for your spatial perception, your visual perception, for your visual spatial perception. So there's something called proprioception, which is where you are in relation to other things. I'm looking at my chair, but like where I am, kind of in space and time. It also helps you differentiate size and shape and color. It's a key component of our eye-hand coordination. And it also contains Wernicke's area, which is responsible for the comprehension and understanding what's being said. And then you have your occipital lobe, that's all the way at the back of your head, at the bottom, and that's responsible for vision and recognition. And so when you saw earlier the brain and the skull, that little model, in the short video where it was wobbling back and forth or being jostled, what was happening there is something that's called coup contra coup. So if I'm rear-ended in a car crash, and so I'm rear-ended, right? And my head, my whole body is thrust forward, okay? So now I've hit the front of my head from that force. And then, again, because of the force, it's going to push me back as well. So I'm going to hit the back of my brain too. So what you see is that people have damage to multiple parts of their brains because of that jostling and because of that shearing that happens too. So somebody might not just have problems with vision. It might be some executive functioning skills. It might be, sensory information. It can be look a whole lot of different ways. And then your brainstem, that's responsible for breathing, for your body temperature, for what I would say are, some of the basics, so digestion and alertness and swallowing. Okay, so then what effect can a brain injury have on someone? What are these changes that I've been talking about? Before we dive into that, I want to show you this video that I think is so excellent. And then we'll talk through why I'm using this video to talk about changes that people might experience.
So I'm going to talk a bit about the journey of brain injury. Everyone's ABI is different, and so that means that everyone's journey is going to be really unique. But I think there are some commonalities. Firstly, brain injuries do improve. They do get better. They never go away, but with the passage of time, they do get better. And it makes me smile to think about all the people I know in my life who don't have brain injuries. And as they get older, their brains are declining, but ours are actually improving. There's also lots of milestones with brain injury. So a brain injury at 2 years is going to look really different at 7 years, and then again at 10 years, and then also at 20 years, which is where I'm at today. For the first few years of your brain injury, it can feel like nothing much is improving, or at least not enough, and it might feel like your life will never be worth living again. I certainly felt that. I went from crisis to crisis with all this emotional instability and lack of memory and fatigue, and I just kept getting myself into trouble constantly. And it was so exhausting. But around about 7 years, things started to change, and I started to have more good things happen in my life than bad things. And since then, that's improved. So a common feature of all brain injuries is the massive challenge to your sense of identity. So much of how you define yourself is going to change in an instant. Sometimes I've called this the great brain injury identity theft. I reckon that this is the biggest existential crisis you'll ever have to face in your life. And most other people will never have to face such a big challenge as this, or have to find the courage and the strength to survive this. So the next time somebody dismisses you, remember this, because you have been to places that few people will ever visit. Almost everyone with a brain injury will tell you about the early years of isolation and confusion. It's not uncommon for about 90% of your friends to disappear. So you're going to have to get used to spending time with yourself. And it might take time to find out that you're not the only one with a brain injury. And it might take even more time to find the community of people with brain injury out there. But when you do find them, it's going to be amazing, but it's also going to be confusing. This journey of brain injury is also going to turn you into some of the most interesting people around. But rather sadly, this is still a bit of a secret. But you are going to develop a whole lot of creativity. You're going to have to, so that you can deal with the challenges of your unique brain injury. And a final thing about this brain injury journey is that it's going to take some time, and you will for sure learn some patience. Everything slows down for us, and things can take just so long to do. And since so much of yourself will have changed, it's also going to take time to get to know this new person. And it's going to take time not just to understand what brain injury is, but also to accept that this has happened to you. And then when you find this acceptance, it comes and it goes. And it can take many, many years before you really embrace and understand and become proud of this new person with your brain injury. You might not be there yet. I'm not 100% completely there yet, but I do believe and I do know that it will happen and we will get there. I promise you. It might feel like 2 steps forward and 1 step back, but ultimately you are heading forward.
I absolutely love this video. And I'll tell you why. So I think with brain injury, because so many people, you get your care in a hospital, and that's so crucial and important. I'm not saying that's not. But recovery and the way that we think of people in brain injury are more in a medical way, like we think of them medically. And I think, we think about what symptoms they're having, what pain they're having, which is all, of course, very important. But I think that this video shows that there's a journey and that it's different from person to person, and that there's a lot of challenges that people overcome and resiliency that people have. And it does sort of raise, as she said, this existential question. And so I just want us to be thinking about how difficult that is for the people that we might work with, or our family members, or clients, or our patients, whomever, right? They're up against potentially a lot and are overcoming that and are being resilient and finding really, as she said, creative ways to manage things. And so I appreciate that she's coming at this from a strengths perspective of like, actually brain injury means you're going to be more interesting and creative. And so as I talk about some of the changes, I just want you to keep that in mind, that there's also changes in strengths and new strengths that might come about, and new resiliency too. So if you want to learn more about some of those concepts and ideas, I'd encourage you to look up the social model of disability. We tend to think of things from the medical model of disability. I won't get into that here, but I'm always happy to talk to you about it. And it asks us to try to accommodate or demands that we accommodate people with disabilities rather than asking them to accommodate us. So I think that she also does a good job of just sort of showing, you know, her strengths and the strengths of people with injuries. So what are some physical changes that people deal with after a brain injury? One of the more common ones I hear is fatigue. And obviously that can be physical fatigue, and often is. But I think what I've heard is more challenging for people is cognitive fatigue. So you have this brain injury, you have something that has made your brain probably work a little bit slower, right? If your brain cells are are torn potentially, and so you have to work even harder, as the woman in the video said, to kind of keep up and to do what you were doing before your injury. So fatigue is common, and it's really good for people to rest and take naps. It's not uncommon for if somebody has a really, you know, cognitively draining day or meeting to need some time to kind of recoup after that, and that should be encouraged. Headaches are common, right? It's an injury to your brain. People might have dizziness, trouble with sleeping. Because our brain controls everything, you might have a change or a loss in your hearing. Speech can be slowed or slurred. And this can be really frustrating for people for many reasons, but one of which, you know, might be that if you're trying to make a phone call or, you know, pay your bill or something online, or not online, over the phone, people might think that you've been drinking. You know, I've heard that story before. And so people can be really dismissive, even though they don't know what's going on for that person. So that's my little plug, to just be kind and know that we don't always know what's going on for people, right? Spasticity can happen. If you don't know what that is, that's where your muscles contract, and it's hard for you to release that tension. You see that, I would say, more so after strokes, but people might also have tremors. People are at increased risk for seizures after a brain injury. So a lot of people will be on seizure medication, or anti-seizure medication rather, even if they've never had one. There might be changes or challenges with motor skills and balance. Might have trouble with coordination. So that could be like hand-eye coordination. It could be more fine motor coordination. You could have a change in taste or smell. So I know, I think of at least a few people who after their injuries cannot smell anything. You know, our brain is really complex and interesting. And some people do have bladder and bowel difficulties after their injuries. And then there are some cognitive changes that might happen. And every brain injury is so unique. It's not like all of these things happen to everyone, or even happen to the same person every day, right? It might vary. So memory can be a challenge. I would say more specifically, it's short-term memory, but it can be long-term too. People might have trouble with paying attention or concentrating, right? If you have to work extra hard to pay attention when you're having, say, a one-on-one conversation, Then you have 4 people in a room all talking at each other and having side conversations. That could be really draining to try to pay attention to that. So sometimes people might seem like they're not interested or concentrating, and it's just that it's so cognitively overwhelming, right? People might have trouble processing. So kind of taking in what information is being said. And so what I always encourage people to do, I think it's good practice for any of us, is to slow down, clarify, make sure that someone's understanding what you're saying, and that they're being understood too. People might have trouble problem solving, and that could be coming up with new ways to solve a problem. And sometimes if somebody's put a lot of energy into coming up with a solution, and then that solution doesn't go as planned, they might be really frustrated because they worked super hard on it. So there's some, different emotions that accompany that. Confabulation is also called honest lying. And that is what happens, for example, if somebody doesn't remember what they did that morning, but you're trying to have a conversation. You say, hey, what'd you do, this morning, Joe? And Joe tells you something that you're pretty sure he couldn't have done. Like chop down trees and drove his truck, but he doesn't drive anymore. And you're like, I'm not sure that you did that, but he's not trying to, or, somebody's not trying to deceive you or purposely lie, just sort of filling in the blanks. And usually it's not the best thing to do to argue with somebody about that. A lack of self-awareness is common. So I'll talk about this in a moment, but self-awareness requires complex thinking skills that can be altered after an injury. Folks might have trouble with organization or planning things or thinking ahead of time. Some people have or develop what's called aphasia, which is a communication disorder. And there's a few types, but the ones I'll highlight are expressive and receptive. So expressive aphasia is where you have trouble making yourself be understood. So you might talk and mix up words or not be able to remember a certain word. And then you also could have receptive aphasia, where we might be having a conversation and everything that I'm saying is just like kind of garbled, or I can't really process it or understand it. And you can imagine how hard that would make, a day-to-day conversation, how much work it would take, right? Some people do perseverate or have almost a persistence about them. And the way that I've noticed it is more about a topic or a certain memory or hobby or interest. And it's like, that person could talk all day about computers or something. And it's almost like they're looping back to that when they can. Judgment could be altered, and you might have trouble with impulse control. And then there's some behavioral changes that the individual talked about in the video we just watched, some that I think are really important to highlight, because I know a lot of times we go right to depression and anxiety, but there's other things that happen, especially if you're having a more moderate or severe injury, right? There's grief around that injury and around any changes that might happen. As she said, there's questions about identity, who am I now? And that's a huge question and a huge thing to, like she said, to sort of figure out and to overcome. And then there is depression, right? And so that could be because of grief around the injury. It could be because of changes to, maybe I can't go back to work and work is really important to me, or somebody's taking care of me when I used to take care of them, and that role reversal is really hard. Maybe I haven't seen my friends in a while. There's all those sort of situational factors. And then there's also your brain might have changed as well, right? There might be physical changes. Some people do experience anxiety. and mood swings sometimes. People might be more irritable for a number of reasons and have more outbursts and be less inhibited, I think is the right way to say that. So people might be set off a little more easily than they had before. Folks might have trouble controlling emotions, right? You have an injury to the part of your brain that manages that. It might be a little different afterwards. Some people have trouble recognizing social cues, knowing when to end a conversation or you're standing too close, things like that. I would say a good amount of people, just anecdotally, have trouble with initiation, with getting started on something. That can be really challenging. And then there might be difficulty in relationships. So maintaining old ones and then also forming new ones might be difficult, right? If you're having trouble with social cues or aphasia or a whole number of things. And then I just want to talk about the lack of self-awareness, because that can be really challenging. There's some really good articles that I'd be happy to share with you about how to deal with that. Because especially if you're maybe a rehab professional and someone's saying they don't have any rehab goals, or you're a loved one and they're saying nothing's different about me, nothing's changed. That's really tricky. But it is pretty common that there might be a self-awareness deficit in people with brain injuries, up to about 97% of the time, or 97% of people. Granted, that is a super old article, so I'm sorry about that. But like I said before, it requires those complex thinking skills that are often weakened after brain injury. But the good news is there are some strategies to work on that. So I wanted to just take this time to really directly myth bust some things and do some stigma busting. But because of a lot of problems with executive functioning, or just because of brain injuries in general, people might seem lazy or unmotivated or apathetic, but they're not. There's something that has changed about their brain, right? Often, in my experience, working with folks, people are trying really hard. And we're all doing the best we can, right? So I just wanted to take a moment to wax poetic at you. So we'll do a poll question, and this is, again, a good chance to take a break and stretch. Check in on your posture. Check in with how you're feeling. Do you need to take a deep breath? Or have a snack or something. Once you've done that, we'll start again, and we'll start with executive functioning. So I'm going to ask you what it is. Is it a set of complex thinking skills that help us achieve goals? Is it B, neurologically based skills involving mental control and self-regulation? C, does it help us get things done? Or D, is it all of the above? And I'm sure that you guessed that it is D, all of the above. All right, let's keep moving along. Whoops. So we're going to talk about some special populations, right? I've said that there are some groups of folks that are more likely to have TBIs than others. So for the most part, I'll tell you a little bit about why that's the case, and we'll talk about a study just briefly. And I'm sure that there's some groups I'm not including. If that is the case, please let me know. I'll put our email at the end here. So we talked about this just briefly, but kids. And I will say that whenever I've talked to people about kids, parents of young kids come up in a panic, and I'm so sorry. Kids are resilient, and they do fall, and it doesn't mean they have a TBI. You know, you want to look out for changes in consciousness, loss of consciousness, really bad injuries, right? But I know that anxiety is hard to manage. So that's my little snippet to start with. Kids, though, are at higher risk of injury because of falls. Yeah, I have, like I said, brothers, and I've watched, my younger brother fall down the stairs countless times. But, that is certainly a cause, especially as they learn to walk. Car crashes, and then childhood abuse as well. Another piece of that puzzle is that children's skulls are, still developing, and are as such thinner than adults. One thing that I would ask you to keep in mind about brain injury in children is that the effects of a childhood TBI may not be readily apparent, especially if kids are not really developing or using their executive functioning skills yet. So what I mean is that a kid might have a brain injury, get cleared, wonderful, and not really have a lot of symptoms, and that's great. But as they get older, say that the child was 6 when it had the injury, then middle school, high school, you start to see some executive functioning challenges. That can definitely happen because when kids are 6, we're not asking them to remember 3 locker combinations. We're not asking them to do quite as much. And the way that schools are set up, their teacher is telling them what to do. It's the same group of people, same classroom. And then when you get to middle and high school, things really start to change. And so sometimes that's when you see kids start to struggle, whether it's with school or behaviorally. There might be outbursts. And that is just something to keep in mind with childhood injuries. Another thing to know is that childhood TBI does double the likelihood of psychiatric disorder by early adulthood, right? So some of those changes in your brain really, really do affect mental health, especially as we age. So if we want to look at a study, this is comparing to children that didn't have a TBI. Kids who by age, 10 to 13 were hospitalized with a mild TBI before age 6. So they had been hospitalized at age 6 or before. We're looking at them at age 10 to 13, right, where we're starting to ask more of them. Kids were more hyperactive and more inattentive according to their parents and their teachers. They were also more likely to be diagnosed with ADHD, conduct disorder, oppositional defiant disorder. They were more likely to have substance use problems and more likely to demonstrate mood disorders. So this is something to keep in mind, if you're an educator or a parent, or educators or parents. If Tim is having trouble when he's 13, we don't automatically assume it's because of that TBI at age 6. That's okay, that'd be a lot to ask of us, but it might be something to just think about, ask if somebody's had a TBI in their past. That way you can know what interventions are more appropriate. So older adults are also, at higher risk for TBIs for a couple of different reasons. So as we age, we have increased fall risks that are associated with lower body weakness, maybe a vitamin D deficiency, might begin to have vision problems or foot problems or pain. If your foot goes numb, makes you more likely to fall. And then also some medications. So blood pressure medications, blood thinners, and sedatives. So just some of the health problems that come with aging can make you more likely to have a brain injury. Neuroplasticity, which is our brain's ability to heal itself and to generate new cells, as far as we know, does decrease with age. We're still learning so much about neuroplasticity, but what we know right now is that is happening more as we're younger. Another factor is that our brains do atrophy over time. Sorry to tell you, they do shrink. And so then there's more distance between the brain and the skull. And that's going to make vessels more vulnerable to that shearing that we talked about earlier with that video, where your axons are pulling apart. So there's some physical changes that might make that more likely. Service members I wanted to talk about. There's been some good research that has come out of TBI being the signature wound of the Iraq and Afghanistan wars. And there are some really helpful resources out there for military people. But I just wanted to talk briefly about why do military people have higher rates of TBI? So they do, first of all. It's more common for military personnel to have a TBI than the general population. A couple of reasons for that. The age group of people who are in the military aligns with the age group, or like the highest incidence age group. So people between 18 and 44 are having more TBIs. A lot of people that are in the military are between those ages. If you know people in the military, it's probably not too surprising to you, but there is a greater consumption of alcohol by military personnel. And at least in my experience, that has sort of, it can become part of, you know, like base culture, or if you're in a rural area, you might rely more on that than otherwise. And then there are people that or military people are at greater risk for injury associated with non-combat military duties. So basic training, you might sustain an injury, you know, different types of jobs that are there, or that are in the military. One thing that I found really surprising when I heard this, because all I had heard really was about the blast wounds and IED explosions, or IED devices causing brain injuries, but about 80% of TBIs since September 11th have been non-combat related. So 20% have been sustained in combat. So in a study in 2017 of 167 veterans, and that's a small group, but veterans with TBI were more likely to have a history of depression, substance use disorders, and other depressive and post-traumatic stress disorder symptoms. They also found that they had poor attention and working memory, executive functioning, and learning memory. Okay, and then homelessness, which I brought up before. A lot of people who are homeless have a history of a TBI. So I've seen some studies come out that show 50%, that show 1 in 4 or 25%, but we'll look at these pretty substantial Canadian studies. It can be really hard to do research with the homeless population just because people are transient. They don't have a place that you can find them at, right? So these studies in Canada in 2004 and 2014 showed that of about 900 people receiving like shelter or meal services, 53% had a history of a TBI. And then a later study at a men's shelter of about 111 people found that 45% of people had a positive screen for TBI. So that's significant. That is a lot of people. And some other things to note are that 73% of people had their first TBI before adulthood. So in those pretty important developmental years, it sounds like. And most people, 87% of people, their TBI had occurred prior to homelessness. And I don't know, very specifically why that is, but I have some ideas and guesses and stories I've heard, right? So if you have trouble with executive functioning skills, really severe trouble, I guess, then it might be hard to stay on top of your bills or even your job. And so that might, economic stress might lead to that. It's tricky, but some people have such big behavioral changes after their injury that it makes their family, it makes it hard for their family to care for them, or for whatever reason they're just not able to. And that can lead to homelessness. Sometimes people might just take off. Again, this is not fact, this is just anecdotally. But there's a lot of reasons why that might be related. The other thing is that homeless individuals are more vulnerable to some causes of TBI, which just horrifies me, but victimization from violence, and then also substance use related falls or overdoses. So I was getting ahead of myself by trying to answer the question of why. There's a bullet point here that says, TBI related cognitive and behavioral deficits, memory, planning, organization, reasoning, impulsive decision-making, comprehension, problem solving, increased risk for economic and housing instability. So that's really important. We need to find out how we can keep people safe and housed. And incarceration is another population, or people who are incarcerated. That's another group where we see a lot of TBIs in people's histories. So the estimated prevalence of TBI in the offender population is 60%. That is so many people, and that varies from state to state. I've seen numbers as high as 80%, as low as maybe 30%. We're just starting to see a lot more of that research come out. Within 5 years of people's brain injuries, 1/3 of individuals report some involvement with the criminal justice system. One study did show a recidivism rate of nearly 70% for people with TBI, which is twice the general recidivism rate. And recidivism is the likelihood that if you've committed some crime or some offense, that you will then go on to commit another crime or offense. And so people with TBIs were more likely, significantly more likely to reoffend and thus have more contact with the criminal justice system. And there's also, associations or the relationship between mental health concerns and substance use disorders, which we'll get to in a little. And then domestic violence. So in abusive relationships, the face, head, and neck are common targets. And that means a few things. So people are more likely to be hit on their head or their face and sustain a brain injury that way. Strangulation is also a pretty common cause of an anoxic brain injury for people that are in abusive relationships. Strangulation cuts off oxygen to the brain, and if you don't have oxygen, your brain cells will then start to die. Another really scary thing about domestic violence and brain injury is that domestic violence isn't just one instance, whereas somebody might fall and it's just that one time, or they might be in a crash and it's just that one time. But domestic violence is a pattern and it's a cycle of abuse. And so that means it might lead, and often does lead, to multiple injuries. There are some studies that do suggest that perpetrators could have a history of TBI. And that might have something to do with their lack of impulse control or increased aggression that then leads to them being the abuser. The effects of TBI, so those symptoms or those cognitive challenges or changes, can make it really difficult for people to assess danger, to make and remember safety plans, to go to school, to hold down a job, and economic stability or economic opportunity, I guess, is one reason. People often do have to stay with their abusers. They can't afford to not. And it also can make it hard to access services and even medical care. So we'll check in. I mean, we just talked about some heavy stuff, especially with domestic violence. Take this time to take a break. Take a nice deep breath. That's what I'm going to do. And maybe reflect or write to me, whatever. What's one new or surprising thing that you've learned as we've been talking? All right, so next things next. We're going to talk about mental health and TBI. And I'll show you a video because I think this person explains some of the relationship between mental health and TBI.
A brain injury often causes a lot of psychiatric problems following the injury because the brain is functioning so differently than it was before. And so the person who has a brain injury understands that the brain isn't doing what it used to. And so they have this sort of odd relationship because they know that they're functioning as a part of who they are, and yet many of them are able to recall what they had. And so there's a lot of work that goes on post-brain injury on the therapy side of things, where people have to begin to cope with the implications of the changes that have happened to them. A lot of times, most of the times, the changes are adverse, something they don't want to happen to them, and so it's very reasonable to become depressed and deeply saddened. In addition to that, the brain's a healthy brain has a lot of controls in place to help us function throughout the day. And when some of those controls are impaired, for example, our ability to tune out stimulation, then you can imagine how you might exhibit signs that seem more psychiatric, like you might be more frustrated or quick to anger, when in actuality what is happening to you is that you're constantly bombarded by stimulation that you can't tune out. And so the good therapist is someone who will be aware of the cognitive issues in brain injury, and also aware that the person is a human with emotions that is grappling with the most complex injury that they can have. And so it's an unfortunate but common side effect to have psychiatric issues following brain injury.
So I'm not sure what you thought, but I thought that was a pretty helpful way to think about why there might be this relation, or why there is this relationship between mental health and psychiatric problems after a TBI, right? There's the emotional response, the grief, the adjustment period. Then there's those cognitive issues that might, like he said, the effects of which might make it seem more psychiatric as well. So a couple of things to know are that some people, right, before their brain injury have a pre-existing mental health condition. And so it might just be that now they have a TBI and they're dealing with that. I mentioned this before, but intentional self-harm is the first leading cause of TBI-related death as of 2014. So people are dying by suicide, and it's the brain injury that is what's causing their death. And plenty of people do survive those suicide attempts and then are living with brain injury. A TBI could also exacerbate some pre-existing mental health concerns. If you had some depression or anxiety before, and now you're dealing with these new symptoms or problems or changes, that is pretty reasonable, I think, is how he said it, that somebody would struggle with their mental health. After a TBI, people might struggle with their mental health because of changes to the brain. As I've said, changes to employment or family dynamics or relationships, and also factors unrelated to TBI. Maybe depression runs in my family. And so, it was maybe a matter of time, perhaps, before that happened to me. or just other things in life are going on that are making this time difficult. If you haven't read this book before and you're wanting to learn more, I absolutely recommend it. It's called The Traumatized Brain by Vanni Rao. Very clear and not too confusing. Sometimes brain injury, you get in the weeds about, brain cells and stuff. And so this just really is a helpful book, I think. And so they write that with regards to depression, that it's common, but it's not necessary. Clinical depression is not a normal part of recovery from brain injury. So we know it happens, but it shouldn't, and it doesn't have to. I'll talk a little bit about some studies. So in one study, about 33% of people with a TBI met the criteria for major depression at some point during a 6-month follow-up. So that's a lot of people, it's 1/3. And not just, general depression, but major depression, so pretty severe. A lot of their symptoms were lack of energy, difficulty concentrating, and irritability. And sometimes depression in men can read more as irritability than anything else. Depression and anxiety are frequent following TBI. The risk of dying by suicide is 3 times greater for someone that's had a TBI. And then if they have a psychiatric disorder or a substance use disorder and a TBI, the risk for death by suicide only increases. And then we do know that people with TBI do have higher rates of anxiety disorders, both generalized and PTSD, higher rates than the general population of psychosis. And some studies indicate higher rates of personality disorders. So what do you do if you are having trouble with your mental health after a brain injury, or your loved one is, or your client is? Of course, you can see a therapist and a counselor, but there are specialists. So there are therapists who specialize in brain injury or who have a good understanding of brain injury. Neuropsychologists are those people. Those are psychologists who understand the relationship between your brain and your behavior. And they are usually equipped to help you. They are equipped, to help you with what you need. If you are needing or thinking you might need something more like medicine-based, so like psychiatry, there are also neuropsychiatrists that again specialize in brain injury, as well as other cognitive disorders or changes. But those are good people to seek out. And the Brain Injury Association has lists of those people in Maryland. If you don't have any of those, which sometimes happens, then you can absolutely ask for accommodations. So if you have trouble with your memory, ask your therapist to provide a summary, written summary of what you talked about. You can give them some educational information about what brain injury is. You can connect them to us and we can try to do some education. So there are specialists, but you can also certainly advocate for yourself, for your family member or client with other people. So I wanted to talk about substance use and TBI as well. And before we talk about substance use, I just want to define what a substance use disorder is. It's a kind of a silly pet peeve of mine, but I feel like in general, people will say, oh, somebody has a problem with drugs or alcohol, but that's a little vague. And so I like to use the term substance use disorder because it's a diagnosis and it also is clearly defined. So the DSM-5 definition looks at a substance use disorder as something that's a habitual pattern, right? It's happening not just once, not just a couple days, but over and over again of intentional and pleasurable behaviors. We all have things that we do that are not great for us, It becomes a problem and it becomes a substance use disorder when the behavior is excessive, too much. That's subjective, okay? But when it becomes problematic too, so there's some really serious consequences across different areas of your life, so your job or your home or your relationships. And when it becomes difficult to modify and stop, that's usually when that's a substance use disorder. So I'm not necessarily talking about like if you have a glass of wine every now and then, but something more serious. Use of drugs or alcohol doesn't constitute abuse or misuse. Okay, but one thing to know is that doctors do pretty universally, at least so far, agree that using substances after a brain injury will have a negative effect on your recovery, and we'll talk about why. But first, the relationship between substance use and TBI. So about 10 to 20% of people with traumatic brain injury develop a substance use problem for the first time after their injury. Okay, so some people never had a problem with drugs or alcohol. After their injury, it becomes a problem. A lot of people are prescribed opioids when they're in the hospital for pain, and that's really valid, but it can potentially mean, you now have opioids in your life, and so that becomes a problem for some people. About 50% of people who are receiving services for substance use disorders, or SUDS, do have a history of TBI. So a lot of people are getting support, but also have a TBI. And then about 60% of people who require inpatient rehabilitation after brain injury have a history of a substance use problem or disorder. A lot of people who present with a TBI at the emergency room have alcohol or substances on board. So a couple more things about substance use and TBI. Somebody having a traumatic brain injury, it can be a triggering event that causes people to stop their substance use, right? Like, no pun intended, but it can be a sobering moment or an eye-opening moment when you now have a fall or a car crash because of your relationship to drugs or alcohol. One thing to know, though, is there is sort of a honeymoon period where somebody might, understandably swear off any drugs or alcohol, where they're like, yep, that's never going to happen again. But elapsed time from a traumatic brain injury, so the further out you are from the brain injury, the higher the risk that people will return to using substances with like a pretty similar pattern of misuse. So, always listen to individuals first, but they might need a little bit more support, and not just a month after, but perhaps more ongoing. And that's the third point. People with substance use disorders before the injury or that have developed one after just might need some additional support when it comes to their substance use. And suicide risk, as I had mentioned, is greater, 2 to 4 times greater in people with TBI. And when there's a substance use disorder or a psychiatric condition, that risk only increases. So if somebody is expressing suicidal intent or talking to you about it, be sure to listen and then try to get the support that they need and support them with that as well. So substance use, I said this again, this is my little hill to die on, but substance use itself doesn't constitute abuse or misuse, but substances can and often do have a negative effect after TBI, especially alcohol. We assume that that's the case for other illicit substances, but they aren't studied. So alcohol is really the one that people look at. Both TBI and alcohol increase your risk of seizures. And that is really scary and could cause another brain injury. And that's the second point. If you're drinking again, that might increase you having another TBI. Or not again if you're drinking. It can magnify and exacerbate cognitive problems. It can exacerbate depression because alcohol is a depressant. So the best practices is to not use any alcohol or substances if you've had a brain injury. That being said, it's not that easy, right? We can't just stop if there's a problem like that. So just so you know, a lot of people do reduce or stop drinking on their own. I think more than we think. If you need support, find somebody who will support you and who will listen to you. You can talk to your doctor, and you can talk to a therapist, a counselor, or a neuropsychologist, and try to get you set up with the right supports that you might need. There are different programs, right? So there's AA or NA, Alcoholics Anonymous or Narcotics Anonymous. There's some other, alternative non-12-step models. So there's moderation management, where rather than focusing on abstinence, you're like, how can I drink or use drugs in a safer way, in a moderate way? There's smart recovery. And then because people are people and we're complicated, and substance use disorders are challenging to overcome, if you're not ready to stop, then you can practice harm reduction, which are things like don't drink and drive. If you know you're going to drink, make sure you're not going to be around a car to reduce your risk of getting in a car crash. Have 1 drink per hour. I'm just listing a couple of things, but there's a lot of things you could do. And that's more about just finding ways for you to stay as safe as you can while you're still engaging in that. Because you have to be ready to change before you're going to be able to change. But there's a lot of support out there. Okay, so speaking of support, we're going to talk about supporting somebody who has a brain injury. So I always think it's important to ask people with brain injuries and to take their lead. And so this is from a website called Brainline, and they just put out to the community, they said, hey, what is the most helpful thing somebody's done for you since your brain injury? And if you have the time, I'd encourage you to read it, especially if you don't have a brain injury and you're working with people with injuries. It's really, it's a really good read, I guess I'll say that. Some of the ones that I picked out were somebody exercised patience. That was the most helpful thing, was somebody was patient. Somebody loved the new me. Somebody said the best thing was you not trying to fix me. Somebody took care of their 2-year-old so they could have quiet time. Someone said, remind me of the things I forgot. And another person said, show me kindly a new way of doing the same task more efficiently. So those are just a couple, but the themes that stuck out to me were patience and kindness, and also just kind of helping out when you can. I also wanted to show you a video of what not to say, right? What not to say to someone with a brain injury. And this is out of Headway, I think in the UK.
I've not looked.
It's all in your mind. Yeah, as if only. Sometimes it's people making comparisons from where they're at.
Yeah.
And they know nothing about me.
Chin up, there's always someone else worse off.
Yeah, how many times have you heard that?
Yeah, loads.
You were able to do that yesterday.
I'm not the same person than I was.
If people say that to me, I'd say, you don't know anything about brain injury and recovery.
I know what you mean. I've got a terrible memory too.
Yeah.
Oh, no. I hate that. Oh, that is so common.
Once, twice a day, everybody does it.
Yeah.
100 times a day, it starts getting a bit peeving.
I say, yeah, but I had a memory before, and now it just doesn't function like it should and like I wanted to, and it's very frustrating.
I really wanted to scream at them, you know what you really have got to do.
I don't actually know how to respond to them sometimes, non-violently. Don't put that in.
I know someone who had a brain injury and they're fine now.
We can all say we're fine. Well, good for them then. Couldn't have been much of one, then, eh?
No.
What I don't like is people say they want the old Deb back. And I'm like, what's up with the new one? You don't look disabled.
Thank you. Well, that's it, isn't it? You've got to, have a stick or a chair or a frame. Or...
Yeah.
Get that many times, eh? Head injury is like a hidden disability.
You can look at us, John, we look normal. But if you grind us for a bit, we'll pick up things.
You should be back to normal by now. Yeah, I wish. That is a common one.
Yeah.
Right. Dread this one.
I don't think people get that head injuries are measured in months and years and not.
I think when you've had a major head injury, though, you're very lucky if you get back to normal.
Crazy. You've got no idea, have you? You've actually got no idea, like what it's like, and they just don't get it. No.
All these people are not qualified to say.
What's normal?
I don't know. I don't think I'd want to be normal anymore.
No.
Because that would be boring.
It seems clear that a lot of people hear the same things a lot, and it's frustrating. So hopefully you've learned a couple things not to say to somebody. But there's some themes, from that we can learn from what people say. And one of those is that brain injury is hidden. We can't ever know who does or who doesn't have a disability. And so we need to be mindful of that and sensitive to people. As you're working with people or, getting to know somebody, ask if they want your support and listen to what they say. This is a common theme with people of all kinds of disabilities where somebody might come up and start pushing their wheelchair or offering them help, but they never asked. So be sure to get consent and respect people's wishes. That's really important. And ask somebody how you can best support them. If that's your role, say what helps you with this or that. And if somebody's not sure, because I find, if I asked that question a few times, so what can I do to support you? And people would be like, I'm not sure. And I feel like I would probably feel similarly if someone asked me such a big question. If they're not sure and they're okay with you suggesting some things, think about some ideas, some things you could suggest. You could say, hey, I can make you dinner. I can call you before your doctor's appointment to remind you. I can take care of your kid so you can take a nap, things like that. It's best, I know it's not possible, we're all human, but to avoid arguing with people, especially if it relates to maybe a memory that they forgot or a self-awareness issue. It usually just serves to upset somebody. And so I would encourage you to avoid that. It doesn't mean you're not honest, but you just don't get into arguments as much. And in that same vein, I would ask you to avoid quizzing people. So what that looks like, and I've seen it, plenty, people will say, hey, do you remember what we talked about this morning? Or do you remember what we were going to do today? Or you don't remember what we're doing today? And that is usually not helpful either. Instead, you might try to offer some cues to jog their memory. Say, hey, we talked on the phone yesterday. And see if that brings anything up. And then say, oh, we were going to go out for lunch today. Right? I think the quizzing people tends to make people feel bad that they don't remember or know what you're talking about. And we don't have any right to be quizzing people at the same time, too. Right? People with brain injuries are people. And We shouldn't be talking down to them. Be patient, right? I think that's important in any field or anytime you're working with another person, but especially if you know somebody has some cognitive changes or difficulties, be patient. And be curious, ask questions, and take the time to get to know somebody. You know, what are you interested in? What do you like to do? Be curious about what life is like for them. So some communication skills, and I feel like I sort of mentioned this already, but treat adults as adults, including avoiding a parenting style of talking. I've certainly heard this a lot, not just with brain injuries, but people with other disabilities. People will say, I already told you about this, or we were going to do this today, and you're not their parent, and they're an adult, and people, you know, can sense that condescension, even if you don't mean it that way. If you're having an important conversation or you're getting to know someone, think about distractions, right? Think about, is now a good time to talk about this? Especially, like I said, if it's important. Has a person already been in meetings all day? Are they agitated? Are we in an area with a lot of people walking by and, you know, distractions or interruptions? Maybe that's not the best time. If you ask somebody about themselves, if you're getting to learn about them, if you're asking, make sure you can and will listen. Even if they talk for 20 minutes, you know, make sure that you're fully there and present. And be patient, be flexible, and be supportive. It's easier said than done sometimes, but I think if you have a philosophy of support and flexibility, that's a little easier than having to adjust your expectations later, potentially. Some other communication skills. Again, this will depend on each individual you work with. So these are just some broad skills and broad ideas, but I suggest introducing one idea at a time and really simplifying, making your communication style a little bit more concise. So you can practice what can be called your ABCs, your accuracy, your brevity, and your clarity. So be accurate and honest. Be concise. You know, you don't need to add all the flowery words like I do. And be clear. So I am somebody that is pretty concrete. And so when I hear accuracy, brevity, and clarity, I'm like, what does that actually mean? So what it can mean is that you eliminate unnecessary words. So it means you might need to think about how you're going to ask the question ahead of time. I'm somebody, it's a really bad habit to break, but I ask like 3 questions at once. Or I'll say, do you want to do this or this other thing? And I've had to learn to stop doing that and just be okay asking one question. So there's things like that. You also might avoid euphemisms or like beating around the bush. Sometimes that gets confusing for people. So be direct and honest. So a bad example of like asking a question or not a question, but a statement would be this. We're gonna go out to eat and I was thinking we could go to a movie after that, but I'm not sure. I checked the weather and it's supposed to be really nice out. So that's not, you know, there's nothing wrong with that. But if you are tired, if you're having trouble processing, there's a lot of parts of that sentence that you could get distracted by. So a better example might be, we're gonna go out to eat. We're gonna get that one idea out, the important thing, and you know, we can talk about the rest later. But that helps people understand exactly what you're saying. So a lot of those last few suggestions came from this wonderful training module. And it's specifically for staff, but I think if you're a parent, if you're a spouse, if you're a child, it just tells you some good ways to communicate with people with injuries. and it has concrete skills, which I always appreciate. So that can be found at the Center for Brain Injury Research, CBERT for short, TBI staff training module. And it's currently free. I had to make an account, but they didn't ask me for money. And then it's about 3 to 4 hours of 14 modules. So it is a great, great resource. I encourage you to check it out. So resources, speaking of, obviously this isn't going to be everything, but I want to hit a few important resources in Maryland. One thing that I have noticed in answering calls from people in the community is that people aren't always sure what resources they need, right? They know they need help with something, but in brain injury and a lot of fields, it can be hard to figure out exactly what. So we have it broken down into a couple of different areas of support. So there's some medical resources. We can connect you with a physician, a neuropsychologist, a neuropsychiatrist. There's educational supports. There's vocational supports, so if you need help with your job. There's some recreational resources, free parks pass, free state parks pass for people with disabilities. There's help for mental health and substance use. There's some caregiver resources, state-based resources, so state programs, and then just different community resources. And we have all of these if you want to reach out to us. A couple of key players that I just want to share with you now are, first one is Maryland Access Point. So this is the one-stop shop for aging and disability resources in your county in Maryland. It's going to be mostly based on like governmental support. So they don't really do much, as far as I'm aware, with private insurance, but they are going to have a lot of good and helpful information for you about what's available in your county. So I have their phone number and website. It's www.marylandaccesspoint.info, and their phone number is 844-627-5465. Another key player are support groups. I have had the privilege to go to a few in Maryland, and they were really transformative, I would say. I learned a lot. And there's some really good people out there that just want to support you. So you can find a listing based on county on our website, and that's biamd.org/support-groups.html. You can find it on our website. For job resources, there's what we call DOORS, the Department of Rehabilitation Services. They do career counseling, career assessment, job placement, job coaching. But their services do depend on your level of disability. And so they sort of look at severity of disability, and there's a wait list for people with less severe disabilities. Their website is doors.maryland.gov. There's also an organization called Pathways in Southern Maryland, in Hollywood. They do brain injury and employment services. Their website is pathwaysinc.org. And this isn't Maryland specific, but there's a job accommodation network. That's askjan.org. And they have a lot of good resources about employment and brain injury. So caregiver support is important too. Very important if you're caring for a loved one with an injury. There's the Caregiver Action Network. I believe they just established a hotline for caregivers, which is awesome. And they have a lot of good resources available on their website at caregiveraction.org. Their phone number is 855-227-3640. And then Maryland Access Point also has a Maryland Family Caregiver Support Program, and that they offer information about any services that are available. Depending on the place, they might have individual counseling, support groups, and caregiver training. They may have respite care, assistance to caregivers in getting access to different services for your loved one. And sometimes there's supplemental services. So you can find that information at aging.maryland.gov. And the Maryland Access Point number is 1-800-243-3425. So there's obviously a lot of other great things out there. And if you have other questions or need more supports, contact us. But those are just the ones I wanted you to walk away with this presentation from. So some other resources, oops, wrong way, that I'll share with you are us, the Brain Injury Association of Maryland. I did not put the correct email on here. It should be info@biamd.org. I'm so sorry about that. Our phone number, our helpline is 410-448-2924. And we can connect you with resources, give you educational information. If I said anything in this presentation that you have questions about, you want more information on, give us a ring or an email. Another very helpful booklet, or online it exists as like a training module, is called Accommodating the Symptoms of TBI. So it has some concrete ideas of sometimes compensatory strategies, some other types of strategies when people are having symptoms of TBI. And their website changes sometimes, but I believe it's at tbi.osu.edu/modules/6. One wonderful resource is the Model Systems Knowledge Translation Center. It's a long name, but they have all of these fact sheets in both English and Spanish. They have web comics about brain injury and videos. So it's really interactive and interesting, and it's clearly communicated. Their website is msktc.org/TBI. They also have information about spinal cord injury. The Ohio Valley Center for Brain Injury Prevention and Rehabilitation has great information. It's ohiovalley.org. Brainline, which I briefly mentioned, that article that asked people what the most helpful thing somebody has done for them since their brain injury was from there. That's brainline.org. Lots of good articles and information, and yeah, just a very good source. So feel free to reach out to us with questions or thoughts. There I have the email. It is info@biamd.org. And because I just, for whatever reason, can't get this right, our phone number is 410-448-2924. I will be updating those. Thank you so much for your time. I really appreciate it. Always happy to hear from you. And I did just want to take a minute to shout out Anastasia Edmonston for all her great work and for training me, and also for letting me use some of her slides for this presentation. All right, so thank you. Take care, everybody.